Good afternoon, everyone. I'm Maya Manian, Professor of Law and Faculty Director of the Health Law and Policy Program here at the American University Washington College of Law. Thank you so much to everyone who's joining us online today. We're so pleased to host this webinar to discuss a terrific new book, After Dobbs, How the Supreme Court Ended Roe but Not Abortion, by David Cohen and Carole Joffe. Today's program is part of our Future of Healthcare series, which features panel discussions that examine different trends, challenges, and opportunities in health law and policy, and that highlights both practitioner and scholar perspectives on a wide range of timely topics. This is the fourth year of this series, and we're so delighted to have reached thousands of attendees nationally and across different industry sectors. Our success with this series is also due to our wonderful partnership with two national organizations. The American Health Law Association, which is the nation's largest nonpartisan 501c3 educational organization that is devoted to legal issues in the healthcare field. AHLA maintains excellence in health law by educating and connecting the health law community. And we also want to thank our other partner, the American Society of Law, Medicine, and Ethics, which is a nonprofit educational organization whose mission is to provide high-quality scholarship, debate, and critical thought for professionals at the intersection of law, medicine, and ethics. I also want to thank our Health Law and Policy Program Director, Asha Shelzo, who serves as the immediate past president of the AHLA and on the board of directors of ASLME, for her continued efforts in facilitating these important partnerships and for ensuring that our program continues to reach a wide national audience. And I also want to thank our wonderful Health Law and Policy Program Coordinator, Tamina Asif, for her tremendous efforts in coordinating all aspects of this event. So before we get started, just a few administrative notes. Please note that live captioning is available and that this event is being recorded. And the recording will be made available on the Health Law and Policy Program's Future of Healthcare website. You should also see a Q&A box where you can post questions to the panelists directly, and we will leave time for your questions at the end of our discussion. So I just wanted to flag that for you now. So today's panel discussion will examine how abortion access has changed in the wake of the Supreme Court's decision in Dobbs versus Jackson Women's Health Organization. And we'll be drawing on the insights of David Cohen and Carole Joffe's groundbreaking new book on this topic. Research has documented a surprising increase in abortions since Dobbs, and their book explains how and why that increase occurred, tracing the legal, the medical, and the practical adaptations that has reshaped access to abortion care after the fall of Roe. So our panelists will discuss what their findings reveal about the limits of abortion bans and the future of abortion policy and access to abortion care in the United States. So I will just give very brief introductions for each of our extremely accomplished speakers, but we will also post links to their full bios in the chat. And I'm so thankful for each of our speakers for joining us today. First, David Cohen is a professor of law at the Drexel University Thomas R. Klein School of Law. David is the co-author of 3 books about abortion, and he also continues to represent Pennsylvania's abortion clinics in various litigation and policy matters. Francine Coito is a public health specialist with over 30 years of experience in the development and evaluation of reproductive health programs. She helped found the Pacific Institute for Women's Health, the Reproductive Health Technologies Project, and Plan C, which she will be talking more about today. Carole Joffe is a professor of obstetrics, gynecology, and reproductive sciences at the University of California, San Francisco. She is the author of 6 books on abortion and has received 4 Lifetime Achievement Awards from various organizations for her scholarship in this area. And last but not least, Tammy Kramenacher is owner and clinic director of Red River Women's Clinic, which was formerly located in Fargo, North Dakota. But after the Dobbs decision, the clinic relocated just 5 minutes away to Moorhead, Minnesota, in order to continue to serve patients in that region. So thank you all so much for being here. I'd like to start with you, Carol and David, to set the stage for our conversation. Your book is titled After Dobbs, How the Supreme Court Ended Roe, but Not Abortion, which already signals attention that despite widespread predictions, abortions increased after Dobbs. So, can you walk us through the core findings in your book, how and why we see these surprising results, and what this tells us about the limits of law-centered approaches to access to care?
Well, I'm going to start off, and thank you so much, Maya, for organizing this, and Asha, Tamena, and American University for providing the platform and the assistance for all this. We're really grateful for the work that you've put into this and letting us have this opportunity. So I was asked to hold up the book for those who want to see it. This is the book. We're really grateful to talk to you about it today. I'm going to set the stage of sort of how this book came about and what we did to do the research for this book, and then Carol will tell you about the findings. So Carol and I had previously written another book, Obstacle Course, The Everyday Struggle to Get an Abortion in America, and that came out in 2020. And what it did was it looked at the ways in which, even though abortion was legal, this was before Dobbs, there were all sorts of obstacles in the way of people getting abortions and how providers and patients navigated that obstacle course. So that was 2020. A year later, or sorry, at the end of 2020, as we're sort of still talking about this book, thinking through everything, in September, Ruth Bader Ginsburg died. And this was when Trump was still president for the first term. And he quickly replaced her with Amy Coney Barrett. And we, Carol and I, and everyone else in the world of, abortion, reproductive rights, and justice, and, anyone who follows the Supreme Court knew that this was going to be a problem, that this was probably going to tilt the Supreme Court to overturn Roe v. Wade. The anti-abortion movement had been trying for almost 50 years to do this, but the numbers on the Supreme Court continued to stymie them. But with Ruth Bader Ginsburg, a staunch defender of Roe, being replaced by Amy Coney Barrett, who had been critical of Roe during her academic career and her judicial career before joining the Supreme Court, the writing was on the wall. And they had the case for it. The Mississippi case, Dobbs versus Jackson Women's Health Organization, had already been working its way through the system. And the case had come out that the 15-week ban in Mississippi was unconstitutional. That's what the lower court said, but they asked the Supreme Court to take the case. And once Amy Coney Barrett was on the court, we had a feeling that the court was going to take this case and probably overturn Roe v. Wade. So this was the talk in our community in 2021, and Carol and I were talking, and we said, you know what, if the Supreme Court does overturn Roe v. Wade, it would be really important to capture what changes took place on the ground because of this change. We have this sort of natural experiment, the before times with Roe v. Wade in place, and then the after times with Dobbs being the rule of the land. And Carol and I are not quantitative researchers. We don't crunch numbers. That's what other people do, and we draw on their work in our book. But what we've done in the past with, Carol's a sociologist, I'm a law professor, but I've done some of this work with Carol and others. We do qualitative research where we interview people who are affected by laws or other policies and ask them about how they're going about their work. And so we decided in 2022, the Supreme Court, as most of the people on this call probably know, decides its biggest cases of the year in June. Tends to. It doesn't have to, but it tends to decide them in June. So Dobbs, the oral argument was December of 2021. We figured it would be decided in June of 2022. We figured it was a very good chance that Roe was going to be overturned. So what we decided to do was talk with people around the country who are abortion providers, advocates, or supporters about how they were planning to deal with Roe being overturned, their immediate reaction to Roe being overturned, and then a little bit later, how they were dealing with it. So what we did was we found a group of about 25 people, different states, different roles in the world of abortion, And we interviewed each of them 3 times over the course of 2022. First, around January 2022, again, about 6 months before Dobbs, asking them questions. What's going on in your world right now? How are you planning for this event, which we think will take place? And then again, right after the decision was June 24th of 2022. So we talked with them in the immediate weeks following this decision, as their world was, drastically changing. We are incredibly grateful. We're incredibly grateful they gave us the time over the course of the year to talk to them multiple times, but especially in the immediate aftermath of Roe being overturned, we were able to talk to everyone in our study again in those weeks right afterwards, what they were doing in the immediate aftermath. And then again 6 months later, so at the end of 2022, beginning of 2023, we talked with them again. Now that things had settled a little bit, what were they doing? What was the difference in what they were seeing? And we had to think ahead of time, different types of people and how they might be impacted differently. We did talk to people in states where abortion became banned, but we talked to people in states where abortion remained legal, or who adapted. And when we went into these interviews, we did not know what we were going to capture. We had no idea what the impact of Dobbs was going to be. Certainly, there had been predictions. The predictions had been that abortion would go down anywhere from 10 to 30, maybe 40% around the country, that half the states in the country would ban abortion completely. And we sort of went in with the assumption that that's what was going to happen. But as 2023 started and we started compiling all of our interviews, looking through them to figure out what we had gathered, um, the numbers started coming out from the groups that were crunching the numbers. So one is the We Count project of the Society for Family Planning. Another one, which came out a little later, is from the Guttmacher Institute, which is a research organization in New York. And what they started finding and producing data that showed was that abortion numbers at first were remaining stable and then were going up post Dobbs. And we, like most people, were getting these numbers and we were like, wow, this is really fascinating. And then as we began reading through all our interviews together, what we realized is that we had captured the story behind these numbers going up. That by interviewing all the people we did around the country, including two fantastic people who are here today, we had the information on the ground about how people were continuing to provide and thus obtain abortions, even though the Supreme Court had overturned Roe. So setting that stage, I'll turn it over to Carole, and she'll tell you a little bit about our findings.
Thank you, David. Oh, Carol, you're muted still.
You would think after a number of years of this one would learn. But anyway, well, first of all, thank you so much, Maya, for this invitation. Thank you to Aisha and Michelle and Tamina for helping this. And thank you, everybody on this call, for coming. As David said, as we went into this really feeling whatever the story is, as abortion scholars, it is important to document it. So we were ready for anything. We had studied the we had studied abortion provision, each of us for many years, sometimes together, sometimes separately. We knew that the provider community and its allies, and by its allies, I mean the national organizations like the National Abortion Federation, Planned Parenthood, the local abortion funds that exist in almost every state. We knew everybody would be doing their best to make access as much as possible. We did not expect the numbers to go up, but as David said, as we were learning about these numbers, we said to ourselves, "Hey, we're seeing it." So what did we find? We found enormous creativity in the abortion providing world. We saw clinics expanding their hours of operation. We talked to one We talked to one medical director of a clinic who said they're open 7 days a week, Sundays starting at 6 a.m. We learned, as you will hear from Tammy, about moving a clinic across state lines. Not a simple thing. Nothing is simple when you are an abortion clinic in a hostile state, but Tammy will tell you how she did it. I was particularly struck by the elaboration of the role of patient navigator. As we talked to people, it was clear how important this was. Patient navigators were people whose jobs simply not I shouldn't say simply, whose job complexly was to help people get to clinics. They they were counseling people from banned states who had never been on an airplane, who in some cases may have been undocumented. They were helping. They were helping with getting the appointment. They were helping with travel arrangements, with hotel arrangements, in very intense one-to-one work that often took several weeks. And they paid for the abortions. And I should say that even before Dobbs, there always had been funds, both national and local, that helped people pay for their abortions. The abortion patient pool, as I'm sure many of you know, it's disproportionately very poor women, half living below the federal poverty line. So always abortion patients have needed help with paying. But this took it to a whole new level. This was about paying for travel, paying for hotels, and being nimble like unbelievable. We talked to a doctor in Illinois who said in the middle of an Illinois winter, a patient was scheduled to come, but there was a snowstorm. Her flight was canceled. Within hours, the patient had a flight to Las Vegas where there was no snow. She had a hotel. She had an appointment. It was just extraordinary effort on everybody's part. The flexibility of the clinics in quote blue states to take people from red states, and at the very beginning, some clinics were literally receiving 800 phone calls a week. So we saw that kind of nimbleness, that kind of creativity. We also saw, and you will hear this from Francine in detail, we learned what an extraordinary important role abortion pills, mifepristone and misoprostol, have played. Francine, who is the high priestess of pills and of getting pills to people, will tell you more about that. Now, our book, therefore, in many respects, gives an unexpected, upbeat look at the situation. When David and I started, I thought we would be sort of adding to the depression many people were feeling, but people were getting their abortions thanks to the extraordinary efforts going on. However, everything we talked about in this book cost a huge amount of money. Right after Dobbs, excuse me, right after Dobbs, there was what has come to be known as rage spending. Millions poured in. People were so annoyed. I mean, annoyed is too mild a word. People were enraged, and they sent a lot of money. We end the book on a more somber note. We end the book raising the question whether this sustainability will continue. And in fact, the donations to abortion funds, have gone down. We can talk more about this later, but just to end very quickly, the latest report from We Count, the organization that tabulates as much as possible every abortion that they know about in the United States. In the latest report, abortions still went up, but by a much smaller percentage. So there are real questions in our field whether or not the things that David and I talk about in this book can be sustained. And I'll stop there.
Thank you so much, Carol, and to you, David, as well, for really laying out, the key findings of your book. And every time I hear you talk about it, I'm just amazed by your foresight, and your skill and the relationships you had built, with the people in this community to be able to tell the story. And also grateful for people like Francine and Tammy who took the time to speak with you. So my next question, actually, I will turn to you, Francine, because I'd love to talk about pills. And one of the most striking features in the post-Dobbs landscape has been the central role of abortion pills, medication abortion, whether by telehealth or self-managed abortion. And who is that reaching that maybe traditional systems fail to reach? So thank you, Francine, if you want to start us off.
Thank you. Thank you all. And really, thank you to Carol and David. And what I want everybody to realize, as a researcher myself, as a public health person, this is gold. This is so rare to have qualitative research on a prospective in a prospective way. One of the big problems with research is often you're having to go retrospectively, but basically by writing this book, Carol and David did catch in advance, and as it was going on, change that was revolutionary. Really, revolutionary is not a big enough word for what happened with these abortion pills. Let me just start back with a reality about pills, abortion pills. They they are so safe and so easy to use that they should be over the counter. That is the premise that we at Plan C started with, and that now more and more and more people recognize. The piece about what happened with the putting the autonomy and locus of control in the hands of the people who want an abortion or who need an abortion is what allowed this revolution to take place, including helping the clinics be able to do more abortions by switching to medication abortion instead of surgical abortion. So from the very get-go, the reason these pills were restricted, they were restricted on purpose. They were medicalized and restricted by the right on purpose because they fully recognized the power of, if these pills got out and were made available to anybody who wanted them, they had lost their battle. Because their battle has always been to go after the providers. We know the history of what happens to very, very courageous people like Tammy and others. That was the way, going after the clinics, passing laws, doing everything possible, killing the providers, just doing whatever was necessary to make sure that the providers wouldn't provide abortions. Well, you can imagine what happened, and this is what has been now documented, is if you take the provider out of the center and if you actually make it so that it becomes a matter of self-managing your abortion, figuring out how to get your hands on pills that are safe and effective, and knowing how to use them, it becomes more available, more private, more well, a lot of adjectives about why the pills became so critical. Now, back to the restrictions that were put on by the FDA, and I know that it's not a good thing to say, but I'm going to say it right now, that when the FDA ruled to make these restrictions on access to the pills, it was political. It was not based on data. The data was already so safe that these pills were so safe and effective, and there was a lot of data from the Europeans and from other countries that showed how safe and effective it was. But by restricting it and making sure that it was not accessible unless you went through providers, and again, restricting who the providers could be and making it so that you had to have really courageous providers using these because they were restricted, is exactly why we had to, starting 10 years ago when we had the idea of Plan C, which was the idea that, hey, if Plan A, which is contraception, didn't work for you, there's Plan B that we'd worked really hard to make available over the counter, which was, another opportunity. If that didn't work for you, wouldn't it be really great to be able to have something you could use to bring down your period or to address an issue that you needed if all the other options had failed? So that was the beginning of normalizing, bringing along providers, bringing along everybody to understand the data and the science behind how safe and effective these pills were. But as things progressed, and this is what's beautiful in the book, I'm so impressed at how you were able to document very complex things that were happening and at parallel times, which is what it took to do. One of the things is we were still very, very, very much dependent on providers because you could not get access to mifepristone unless you went through a provider who, I see Tammy, doing this with her head. I mean, it was on purpose. You had to find a provider who could prescribe the pills for you. Otherwise, the opportunity to self-manage wasn't there. So we began to explore and experiment with all the providers that, desperately trying to do what they could. COVID was, my husband jokes and said that one of the best things that ever happened to Plan C was COVID. I don't know that that's a good joke, but it helped because it was sort of like at the time of COVID, we were able to say, wait a minute, to providers and to Planned Parenthoods and to clinics, are you really going to insist that somebody come to your clinic during this time when we're all being told, stay home, don't go, why don't you just mail the pills? So this idea of mailing, which again was very, very scary and notorious, and it wasn't clear whether the FDA would approve it, whether it was a part of the FDA, whether we had to start fighting the legal fight and the regulation fight, and really began to show that in fact in the REMS, these restrictions that had put in, there was nothing that had said that you couldn't mail. It was just that they insisted that there be a relationship between the provider and a client, and the idea of telemedicine started to come on board. Anyway, that revolution of telemedicine happened that allowed us to move towards mailing. That said, I'm going to go really quickly through because I think it's really important to hand it over to Tammy to talk about the challenges of again, the parallel movements that had to happen. We began to see that the states were beginning to pass some really egregious laws, again going after the providers, and even even bounty hunters promising bounties to anybody who would turn someone in, either someone who was aiding and abetting, which clearly I was aiding and abetting. I was going around into Texas with a billboard that said, hey, there's these pills for you. Tammy was definitely an aider and abetter. I mean, they were passing these laws that were very egregious. And so we began to realize we needed to get the politicians involved and pass laws that would protect the folks who were courageous enough to do the work that they were doing. And so that began the whole idea of shield laws, of passing laws in the states that, blue states or the states that were liberal, that would protect the providers who were shipping and mailing pills. And that was critical because we could see very quickly, and this was very well documented in the book, that we were going to end up with two countries: a country where you were in a blue state and you had access to abortion, or you were in a red state and there were no clinics available anymore, and there was nothing available unless somebody shipped you the pills, or you could get access to the pills. So the Shield laws, and I'm going to stop about that because David could tell you a lot more about the Shield laws. They were critical. They still are critical. I'm going to just end this part of what I want to tell you with the fact that bringing you up to date on the what they're trying to do. We have managed to have I want to say I don't last count. I think it's maybe 9 providers, shield law providers, meaning providers who live in a state that has promised to shield them, who are willing and able and mailing to all states everywhere, including the territories. And so, thanks to them, everyone in any state can have access. And I will talk later about access of cost. That was another thing we worked really hard to make sure that it wasn't people who couldn't pay would still have access. We were able to do that. But right now, the latest is they're coming after the shield law providers that they can identify. And there have been 2 providers, shield law providers, who have been indicted, and they've been asked to be extradited to Texas and to Louisiana. They are now very public. Maggie Carpenter, who was one of the first ones to be identified because they found her name on the prescription bottles. And then most recently, my brother, who is a provider from California, who also, because of the prescription bottle, was identified as mailing, and who's been criminally indicted. And it's really, really scary times out there again, because not only were these 2 providers accused and indicted, but they were doxxed. Their information as to where they live was made public, and they've had to move. It's really, really difficult times. The amazing part of all of this is these shield law providers are continuing to serve, and people like Tammy are continuing to figure out creative ways to continue to do what they do. So I'm handing it over to you now, Tammy.
Actually, Tammy, before I jump to you, I'll just quickly go to David. I know, David, you were a key developer of the concept of shield laws and, participated in helping to pass one of the first shield laws. I know the landscape on all the legal battles around pills is very complicated. Do you have, a little bit you want to add on the legal issues, on shield laws or other issues around pills?
Yeah, I mean, this is such a key part of the developments post Dobbs. We're now at around 70% of abortions in the country are through abortion pills rather than procedures. And that's just been going up in the past several years. And the anti-abortion movement knows that. And like Francine said, they are petrified of what this means. Post Dobbs, there are 18 states that shield abortion providers, meaning they say that we will not participate in any out-of-state effort to make our providers civilly liable or criminally liable for what they've done. And that started as an idea to help people caring for travelers, that if someone crosses state lines, goes home, and then sues a provider, family member might sue a provider, we're going to protect you. There are 8 states with explicit protection for providers who mail into states where abortion is banned. And those are the providers that Francine is talking about who are in the legal crosshairs right now. Texas and Louisiana are the 2 states that have done the most so far to stop shield provision. They have not successfully done so. There are a couple bills in Indiana, South Carolina, and a couple other states that are trying to go after shield providers too. But this is constantly on the radar of the anti-abortion movement. Because they know that this is undermining what they thought would be the result of Dobbs, which is that abortion numbers would go down. Last point, and this is another thing that Carole and I end our book on, which is that there are 2 federal legal issues, or 3 federal legal issues around pills that so far, at the end of the book, we finished the book mid 2024. We didn't know what was going to happen with respect to whether the FDA was going to change the fact that you can mail pills. That has not happened yet. The anti-abortion movement desperately wants Trump's FDA to do that. It has not changed. They desperately want the Trump administration to enforce an 1873 law called the Comstock Act that would ban mailing anything that can produce an abortion. So pills being one thing, but also instruments, supplies, equipment. And that law, which hasn't been enforced really since the 1920s, the anti-abortion movement has a really radical interpretation of it that they want basically all abortion, anything related to abortion, not to be able to be mailed, to be a federal offense. And they're also desperately asking the Trump administration to enforce that through the Department of Justice, and they have not. So, when the book came out, we thought that was possibly going to happen. But so far, a year into the Trump administration, he's done all sorts of other outrageous things, but has not done these two things. And then third, and then I'll stop, there are multiple challenges in federal court to the FDA's approval of mifepristone back in 2000 and its changing of the requirements, particularly around mailing mifepristone. That change happened in 2021, was made permanent in 2023. And there are lawsuits in federal court in Missouri, Texas, and Louisiana raising these issues from anti-abortion states that want to force the FDA to go back on what it's done. The lawsuit probably the most important to pay attention to right now is because it seems the quickest to be moving is the one in Louisiana. There's a hearing at the end of this month on the preliminary injunction that the state of Louisiana has asked the court to impose. And just last week, the Trump administration filed a brief asking the court to delay its hearing because supposedly the FDA is undergoing a review of the safety of mifepristone, something that's been studied probably more than any other drug, and has been found again and again to be safe and effective. But the Trump administration is saying, one, delay the ruling because we're studying this, but two, that the state doesn't have standing. So is asking the court to throw the case out because of lack of standing. So the Trump administration, in a way, is fighting this lawsuit too. So it's doing some things that I think many of us predicted it would do the opposite of when it comes to abortion so far. And we can talk in the Q&A about why that might be. But so far, these efforts on the federal level to restrict pills have not happened. And so I'll leave it at that.
Thank you so much, Francine and David. So, Tammy, finally, I will turn to you on clinics. Pills have expanded access in various ways, but brick and mortar clinics like yours are still, hugely important in providing abortion care. So we'd love to hear your perspective as a clinic director, what has changed since Dobbs and what might people not understand about what clinics are absorbing and managing right now.
Thank you. Thanks to everyone. As everyone has said, thank you for having me here, and thank you to all my other panelists. I'm finding it fascinating. So, the biggest thing, and I just want to, reiterate the importance of brick and mortar clinics. Organizations like Plan C and places that do mail pills, especially to states that I serve the majority of patients from, like North Dakota, where there is a near total ban, are incredibly important. But there are still many, many patients who want a procedure abortion, might be past the, gestational limit for a medication abortion, or have real fears about, bringing those medicines back into a banned state. And so at our clinic, I actually just quickly double checked my numbers. About 51% of patients chose a medication abortion in 2025. So another, 50-ish% chose a procedure abortion. We don't really ask them, why, if somebody is under where we provide up to 11 weeks for a medication abortion, we don't ask their reason why they chose one over the other, but patients will often tell us. about their fears of bringing the medicines back into another state, or they want to know that the doctor did the procedure. They want to not be pregnant when they leave the building. They don't have time to do the follow-up, all those kinds of things. So I just want to put in a plug for remembering that procedure abortion is still incredibly important. But really what has changed the most, is the access landscape. My clinic, we were able to move 5 minutes away from our old location. We are incredibly fortunate. I shared with David and Carole the sense of survivor's guilt, I had about seeing so many of my friends and colleagues losing clinics and having to move multiple states. And so I feel incredibly lucky that, we were able to do that. But what has changed mostly for patients, and not even in our region, but all over, that patients are having to travel even further to obtain, abortion care if they can't get it mailed or choose to have a procedure. And this leads to all the most obvious difficulties for people having to arrange childcare, time off work, pay for travel, gas, hotel, food. Especially patients in the South have to travel multiple states to get to a clinic. And like Carole talked about, that takes enormous resources from the clinics and the local abortion funds and the patient navigators to help people facilitate that travel. Many clinics have taken on increased patient caseloads and in order to keep up with the increased demand if they're in a safe place. And this leads to staff burnout. This is my 33rd year in abortion care, and I still love coming to work every day. But there have definitely been some times after a long clinic session where I have said, this commitment to a cause is really draining sometimes. And then specifically closer to home in the Midwest here, what we hear on a regular basis from our patients is a real fear about traveling from a state that has banned abortion. Is it even legal for me to come there? I live in a banned state. Do you have to tell them I came to you? And the most heartbreaking question from a patient was, will I be prosecuted in the future for the health care I'm receiving today? Providers also have to navigate the ever-changing legal landscape. For the past 3+ years since Dobbs, we've been in litigation with the state of North Dakota, and it could change month by month, the legality, with the drop of a judge's pen. A lot of clinics have been dealing with the ping-pong volley of back and forth legal rulings. It's also, it's a lot to manage while also being, human beings ourselves, and dealing with all the turmoil that's going on in our, world right now. There's, like David mentioned, there's concerns about medication abortion being available in the Comstock law. When Trump first came in, we looked at the, playbook they had, and a lot of clinics stockpiled supplies, and that takes financial resources, as Carole mentioned. We were able to get some funding to help with that, but we put in a 6-month supply where we're a clinic that normally carries a 1-month supply of all of our medicines and instruments. And so we made the commitment to have 6 months so that if the Trump administration did enact the Comstock law or ban medication abortion or somehow, that we would have at least some on hand to be able to take care of people. And then right now there's a real fear in clinics about the likelihood of increased violence at our sites. A very well-known anti-abortion protester, Randall Terry, is pushing to revive the invasion and blockade tactics from the 80s and 90s. I've been around long enough to, the very first day I was going to go work at the other clinic that used to exist was the day before some people had blockaded the driveway and drove these junked cars, to try and restrict people from getting into the clinic. And Donald Trump has pardoned these violent protesters who have besieged clinics. And there's renewed interest from these anti-abortion folks to bring back these really violent tactics. So a lot of my friends and colleagues are, who can still provide care are very pleased to be able to do it, but it's under enormous duress, and really impactful, emotional, even more so than ever, with our patients and having to, routinely answer these questions about legality and are they going to get in trouble. We've had patients, we serve a large indigenous population saying, they feel like they were followed by a federal vehicle on their way to the clinic. These are just things that we haven't had to navigate before. So it's an incredibly difficult time, and it can change day by day, week by week for providers.
Thank you so much for sharing all of that, Tammy. I think it's really important for people to hear both what your patients have to go through to receive care, and then, also what you and your staff and your team have to face. And, the threat of violence is real and very frightening. Carole, did you want to follow up, and tie it with other themes you found with regard to clinics with the people
Right.
you talked to?
Well, first of all, I thank Tammy for reminding us that even though creative providers like her have solved some of the new problems, that there still are the same problems that have always been there in abortion care. And security, both for providers and their patients, is always there. Uh, Donald Trump made it clear that he will not enforce the FACE Act with respect to abortion facilities. And when under Democratic administrations, the FACE Act, the Freedom of Access to Clinic Entrances, passed in 1994 by Bill Clinton, that really made a difference. And it is very upsetting to hear that these blockades may be coming back. But let me start on, I'm actually going to read a tiny bit from our book about clinics that have closed. But first, let me tell one of my favorite stories from the book. It's a Tammy story. When Tammy was in the midst of moving her operations from Fargo to Moorhead, yeah, she said 5 minutes away across the Red River, as she was getting the clinic set up, she received a phone call. She saw on her cell phone a number she didn't recognize. And as a parent, you always worry, well, is something wrong? She picks up the phone. The caller says, "Hi, this is Senator Amy Klobuchar. I just want to welcome you to Minnesota." And to me, not only as a friend, admirer of Tammy, but as a sociologist who is obsessed with the status of abortion providers, this was really a turning point. Later, she was visited by the Attorney General of Minnesota, the other senator. Later, she was invited. She and at least one other provider were invited to the State of the Union address. And I know I'm making a big deal out of little things, but that's what we sociologists do. This told me what the changing abortion politics were like at that moment. The Democratic Party that had always been squeamish about abortion, yeah, we have to support it, but we don't want to talk about it. Now providers are going to the State of the Union. Okay, what I'd like to do now, though, is talk a little bit about what happened to clinics that closed, or if not closed, could no longer provide abortion. And this was one of the most, speaking very personally, one of the most difficult parts of the book for me to document, because as someone who studied abortion provision for many years, I have come to understand that it is people's life work. It is a calling. And to suddenly be told you can't do that was very difficult. I'm going to read you very briefly about one of the people we profiled in our book, Dr. Leah Torres. She was the medical director of a clinic in Alabama, the Western Alabama Women's Center. And abortion was her life's work. We asked her when we were talking to her about what it was like when she first heard about the Roe decision. In a wave, it hit me. You are not a citizen, equal under the law. And my profession became a criminal act. You might as well ask me, how do you process the fact that aliens have landed on our planet? And then I want to give you a sense for what it was like for abortion providers in states where abortion was banned, who who could not even, who didn't know what the legal risks were of actually referring patients elsewhere. Alabama, I mean, the Attorney General was very aggressive and very upfront about going after providers. It wasn't clarified for a number of months that, yes, it was legal. You could tell a patient where to go. But at this point, when we spoke to Leah, it wasn't yet clear. So I'll just read this. The emotional toll on Leah of no longer being able to properly take care of her patients was devastating. I couldn't have anticipated what that would be like. I knew it was going to be hard, but when you've got someone who has 6 kids already, doesn't speak English, can't read or write in her own native language, begging for help with not having a 7th child, nothing can prepare you for what's that like. Now, so just to wrap this up, I mean, a lot of the abortion workforce in the states where clinics were closed, a lot of them, quote, lost their life works. Those who are physicians, of course, could fairly easily transition to another place where they could make a living. Leah actually has now runs a clinic in Colorado where she does provide abortions. The West Alabama Women's Center is still open, but not providing abortions. But a lot of the people who've worked for many years in abortion clinics, the lower level staff, below the clinicians, the receptionists, the medical assistants, who've given their life to this work, their resumes, they are very often uncredentialed. They've really worked. They've really learned by working as apprentices, and this part of the workforce has been hit very, very hard. Okay, I'll turn it back to you, Maya.
Thank you. Thanks for reading those very moving passages from the book. And I love that story about Senator Klobuchar as well. It's a great story. So I want to move to an important question about who is still left behind. I also just want to quickly remind people that you can go ahead and start posting questions in the Q&A. We're aiming to wrap up around 10 after or 15 minutes after the hour, so there will be some time for Q&A if you want to post your questions. But one of the central themes in the book is that even as abortion access has been maintained and even increased, it remains deeply unequal. So we wanted to make sure we talked about who's being left behind still and how. So maybe I'll start with you, Tammy, because of your geographic location. What do you see where you're located in terms of who's being left behind?
Well, in our region, North Dakota and South Dakota used to have, one clinic each. And after Dobbs, even after lots of legal wrangling, now there are, no clinics in those 2 states. Iowa has a 6-week ban. Wisconsin has been on and off, over the time. And so what really is happening is, we're serving an enormous geographic area, those of us who are in Minnesota. The state of North Dakota, where 70% of our patients come from, I Googled this quick, 70,000 square miles. South Dakota is 77,000 square miles. Like I said before, we also serve a large population of Indigenous patients at our clinic. These patients have unique circumstances and challenges that affect their ability to travel and access quality health care. And because of the distances involved in traveling to a clinic, rural patients who might not have reliable transportation. In our part of the country, weather can play a huge factor in getting to a clinic. Major highways are often closed in our region with bad weather. Patients who have to account for their time. It's difficult to, be gone, travel 3-4 hours one way to a clinic, spend a couple of hours at a clinic, and then travel home. It might not be safe for them to be gone and not be able to explain where their whereabouts are. Patients who are caregivers who have no backup. Young people who might not be able to discuss their situation with a parent or guardian. It's kind of the same old story, pre-Dobbs, post-Dobbs. Those with privileges and the means will always be able to travel elsewhere or take the risk of having, like pills mailed to them because they don't have to worry about the color of their skin or who's monitoring them. And those without privileges are often still the ones left behind and forgotten.
Thank you, Tammy. Carole, can I turn to you to talk about what's happening, in hospital ERs and pregnancy complications?
Um, I can answer in one word: chaos. As Tammy said, I mean, it's the sickest who are left behind. They can't travel, even if they had access to the resources. What's going on in hospitals is actually, interestingly enough, not unlike the pre-Roe era. Pre-Roe, people still had problem pregnancies. People still needed abortions for medical reasons. I'm talking now about women experiencing pregnancy emergencies. In the pre-Roe era, hospitals didn't know what to do. There was not the same highly developed anti-abortion movement that we have today. The way it was settled then was through, quote, hospital therapeutic abortion committees. A number of doctors, usually all male, would get together and decide if someone's case was, quote, pathetic enough, to get an abortion. In my earlier work, I talked to a woman doctor, now deceased. Tammy, you'll remember her, Millie Hansen, in Minnesota. She got herself on one of these committees pre-Roe, and she said she and her allies looked how much money. They knew they had a quota. They wanted everybody to get an abortion, but they knew they couldn't. So they decided, well, if she has enough money to fly to New York, where it was legal by 1970, we'll deny her. If she's really poor, we'll say she has to have an abortion. So that's happening now. But now it's very often the hospital council making the ultimate decision, not the doctors. The doctors can say, "Look, she has ruptured membranes. This is a risk of death." Another doctor might say, "But there's still cardiac activity in the fetus." So there's just very tense, often very uncollegial, tortuous things going on between medical colleagues. At UCSF, we did a study called Care Post-Roe about exactly this. We talked to doctors in both red states and blue states, what has changed since Dobbs. And in the so-called red states, what has changed is the things you used to routinely do an abortion for, even if your state had limitations. If someone had ruptured membranes, if someone needed an ectopic, a pregnancy because of an ectopic, you just did it. Now that is different, and inevitably, not surprisingly, we've seen real tragedies. I'm sure many of you have heard about them. ProPublica, the investigative journalism outfit, won a Pulitzer, by the way, for its documentation of women in Texas and Georgia who have died because of care that was either denied or offered too late. So it's still a very chaotic situation. There's been a lot of public outcry. I think the media has done a good job of publicizing some of these very hard cases. Some of the states have backtracked a little, trying to clarify. Okay, look, you can do them for ectopics, but obstetrical emergencies are not predictable, and they can occur for a variety of reasons. Saying you can do an ectopic, which everybody agrees is life-threatening, that doesn't speak to hundreds of other situations. So it's chaos and cruel.
Thanks for bringing all of that to everyone's attention, Carole. So I want to wrap up, hopefully moving on a more positive note. Obviously, there are, you know, even though abortion numbers are up, I don't think your book is claiming everything is all good, right? There are still very much, catastrophic consequences for many people. My final question is, what do each of you think is most essential to sustaining abortion access going forward as far as possible? So, Francine, let me start off with you, since your focus is on pills, and that's such an important aspect of sustaining access.
Oh, thank you, Maya. Thank you. Hearing all of the, the horrors of how difficult it is for folks who really do need access to providers, to really good providers who can help them either for maternal care or for abortion. Um, I do have to just point out that the numbers that we're seeing and the story that we're seeing that the numbers are up since Dobbs really, really do have to do with the pills. The number of people who have traveled is minimum compared to the amount of access that has increased because people can get the pills mailed to them. The fear is that the attempt to make sure that nobody gets left behind um, was a huge part of what all the folks that were mailing and all the people who were putting up websites and all the abortion donation groups were working on were several. One was to make sure the cost was not going to be the reason why people didn't, if you couldn't afford it, you weren't going to get it. That was dealt with straight up. It's pretty amazing how low the cost is to get medication abortion, and how many of the providers provide a sliding scale and make sure you get it if you cannot pay. So the cost piece, which was one of the things that was predicted, which was, oh my goodness, it's going to be all the privileged people who can afford the care who are going to get these, and the other people are going to get left behind. That is not the case. It's not due to cost that people are being left behind. The other piece that was a big scare was, well, what about the people who need second trimester or, further care further along? What was going to happen to them? Well, one of the things that happened was because getting access to medication abortion got rid of a lot of the barriers to care, even just how long it took to get an appointment when the clinics even existed. Say, let's take Texas, for example. It took, you would lose time trying to get into a clinic and therefore be into the second trimester. And what started happening with pills is people started coming earlier and earlier and earlier, asking for an abortion, recognizing they want an abortion, and changing the percent of people who ended up needing to be in the second trimester. So that helped with not making sure that those people were not being left behind. The biggest challenge or the biggest fear, and somebody just mentioned I think it was you, Carol, said the risk of pills. No, I think it was Tammy. The risk of pills being mailed to you. That is the biggest fear now that the right is trying to propagate, because that's the last thing they have is to threaten people with, oh my God, if you get caught having these pills in Texas, you're going to go to jail. Well, honestly, and again, I will turn that to David. Ironically, self-managing your care is not illegal. The reason they're going after the providers is because you can't really go after the woman who took the pills, because it's not illegal to take pills for your own self-care. So a lot of the fears are meant to be a barrier on purpose. And the numbers, one of the most important piece that happened with how much we worked with Guttmacher and with WeCount to get the numbers out there, was to point out that the denominator of the number of people who were getting pills mailed to them and were meeting their needs by mail was huge. And the number of people who'd gotten caught, so that the risk of having pills mailed to you, and we're talking in the worst states, Louisiana, Texas, Alabama, the ones who are the most egregiously trying to get you, were very, very low. And they weren't for having mailed the pills. That is how they get the providers. They were for how you were getting rid of your of the remains of your pregnancy. And again, those didn't go anywhere. Most of those lawsuits did not go anywhere. They were just there to scare people. So I just feel very hopeful. I do feel very hopeful because I believe we have created a tipping point in which people have learned that they can take care of their needs by many different approaches. Being able to go to clinics like Tammy's if they're close enough and they have the resources. Finding out where they can get to those clinics, finding out who can mail them, and then feeling more comfortable. The amount of talk on Reddit about, is this for real? Because this, can we really do this, is huge. We're getting to the point where it's becoming mainstream enough that people are doing that. And then finally, the other piece is, if the FDA were to pull this and say, hey, guess what? We actually think this is so unsafe, we're pulling this product off the market. There are websites that will mail you the pills. For about $100, you can get the pills. We double check that they're the good pills. They're the same pills that you would get if you get it through a provider. I mean, I think we're getting closer and closer and closer to being where we should have been when we asked for approval of mifepristone, which was, here is a product that is so safe and effective that it should be over the counter.
Yeah, I mean, there's always ways around, and there have been in other parts of the world for a long time. So as we wrap up, I would love to ask Tammy and Carole and David to each share, one thing maybe that you think would, or one thing at the top of your list that would help sustain access to care. I'll start with you, Tammy, if you have an idea at the top of your head.
I have lots of ideas, but I will, to talk about just being involved politically. I mean, how can you not at this point in our country? But going particularly from a red state like North Dakota to a blue state like Minnesota, and the very first law that they passed in the 2023 legislature was the PRO Act, which was to protect abortion access. There was a trifecta in the Minnesota legislature. So who sits in the local government, the state house, and the White House all matter. And wrapped up in that, with voting and who's in power, is I'm going to do two things, is the funding. A lot of clinics want to accept Medicaid where it pays, but the reimbursement rates are abysmal. Like Carole mentioned, local grassroots abortion funds can't be the stopgap forever. We need real policy change to ensure that both Medicaid and private insurance covers abortion at reasonable market rates that cover clinics' costs.
Thank you, Tammy. Carole, do you want to go next? Oh, you're muted. Oh, Carole, you're muted.
Everything Tammy said, and voting at every single level. It is so, I mean, it's not enough if you care about abortion to vote for president and senator. Judges, before Tammy mentioned that in Wisconsin it's been on and off, but now abortion is happening really for one reason. They changed the composition of the Wisconsin Supreme Court. That's why that's why abortion is happening there. We have seen at every level of the Trump administration's egregiousness that the courts have been really our firewall. So it is essential to vote at every level.
Carole, David, Do you want to wrap this one up?
Yeah, I think, what I take away from all this and everything happening is not to let law make you feel like it's not worth fighting. The Supreme Court is terrible. There's a lot of bad law happening. Lower courts are doing bad things. There are states doing bad things and making bad laws. But there's so many ways to fight around bad laws. And we're seeing two people on the call today who are doing that. The people in our book are profiled people who are, saw what the Supreme Court did and said, we're doing it anyway. We're going to find a way. They're not breaking the law, but they're doing it anyway in ways that are creative and interesting. And I think everyone else needs to have the same mentality because it's easy, especially in the world of lawyers and law professors and other people in the world of law, to think that what the Supreme Court or what a legislature does is the end of everything. That is it. That's the end of the discussion. It's only one drop in the bucket of what people can do. And then people on the ground and those of us who support them maneuver. So I think we need to have the same mentality as the people we have in the book, that we will maneuver, we will fight, we will resist, and law is not going to end it.
Thank you. I think that's a great call to action, especially for us lawyers and law professors who are trying to teach constitutional law right now as we sort of see it shredded before our eyes. We have lots of great questions in the Q&A, and I'd like to get to as many as we can. So speaking of shredding the Constitution and having someone from Minnesota on the call here with everything that's been going on in Minnesota, one of our questions is, as we've been discussing, power and privilege have always shaped abortion access. So maybe you, Tammy, or others can also, if you want to start us off and others can chime in, can you speak to ways, if any, that the current ICE, and I'm quoting the question here, ethnic cleansing campaigns affect patterns of abortion access?
Well, thankfully in our part of Minnesota, I mean, there's definite sightings of ICE, but I'm going to speak for my colleagues in Minneapolis. There's an independent clinic, Whole Woman's Health in Bloomington, that I've been in touch with, and they have a nurse, for example, who is in the process of doing everything legally to get asylum and get her immigration status here, but she's been told by her immigration lawyer not to leave the house. So they have not had a nurse in their clinic for a couple of weeks. I have a former intern of mine who got a job there, and she is Mexican. She is a U.S. citizen. Her father is not, though, and so she has real fears about, just walking around and going to and from the clinic. And then the people who are, sheltering at home because of fears of leaving their home and being targeted by ICE, we know that there are pregnant people who need care and are being, thwarted in that. So it's both the patients themselves facing challenges, the clinic having staffing challenges. That clinic in particular were notified by the apartment building next door to them that ICE was at the apartment building right next door. They have a shared parking lot. So there was very real fear for their staff and their patients. And so it's, even in our clinic where we have a very different situation up here. I mean, 2 weeks ago, we had a Somali patient, we had a Haitian Creole patient, we had 2 native Spanish speakers, and we had an Arabic speaking patient. And these are real challenges for those folks. And our escorts, I saw there was another question about escorts, and I hope we get to that. Our escorts who are really on the front lines have to be worried about, ICE agents showing up at our clinic too. And we have to make a plan for that. So that's also a challenge, is how do we handle it if, masked men show up at our clinic? Those are discussions that a lot of people never thought they would have to have.
Yeah. Well, Tammy, why don't we...
Can I just add one quick thing?
Okay, go ahead.
And I'm glad Tammy mentioned this, in the spirit of thinking about reproductive justice and not just abortion, right? That the impact on people who are pregnant and want to continue their pregnancy and give birth, right? That people staying home, not getting care. The New York Times had a really great short video yesterday that I'm going to send you, I can't send it to everyone in the chat, but I think someone else might be able to do that. It's worth watching. It's like 4 or 5 minutes long, and it's just about some people in Minneapolis who are, struggling with how you can go out and get prenatal care and birthing care when you fear for what's going to happen if you walk out the door. And it's just tragic. And I'm glad the New York Times highlighted that issue, that it's not abortion, but it's pregnancy care, and that's reproductive justice.
Yeah, thank you for highlighting that, right? Abortion is one aspect in our whole healthcare system, which is, has huge disparities across the board, and we see that in abortion just as we see that in other kinds of care across the board. Tammy, since you mentioned that other question that someone was asking about, clinic escorts, organizers, abortion doulas, do you want to speak to that as well, like sort of the volunteers that are out there who are also discussed in David and Carol's book?
And I had the privilege of Carol coming to visit Fargo one time to kind of see the lay of the land here. Thank you for asking that question. I think the person's name was Anna. Our clinic escorts at our clinic are so vital to the entire wraparound experience that our patients have. At our old location in downtown, we were literally patients had to walk on a sidewalk, and the protesters are right there in their face. And those escorts provided that, safety, security, for the patients. And at our new location, thankfully, we have a parking lot now. The protesters do, stand at the driveway and try and actually stand in the street, try and get people to stop. But I can't emphasize enough the importance of clinic escorts, those unpaid volunteers who show up, especially at our clinic when it's 20 below, rain, snow, sleet. They are here. Sometimes they beat us to the clinic. They are a community amongst themselves, and they are truly part of the patient experience. We don't use doulas. We don't have a professional or even unprofessional sort of connection with any local doulas. I feel like a lot of our staff can play that role. But so how you can get involved, I think was the last part of the question is, there are some very formal programs at our clinic. We just have it, go to your local clinic website. They probably have information on how to get involved. Some use their local, NARAL affiliate to do the vetting and training. Some clinics like ours are just, we've got a couple of long-term escorts who are kind of our lead escorts, and we have a manual. But reach out, see what you can do. It is vital that those escorts are out there, and they truly are the frontline people. They're the people whose safety and security is most sort of out there. And we're just so grateful for them. But most clinics, you are going to be able to find information on how to get involved. There's also the Clinic Vest Project. That's another way to be involved. They provide the rainbow vests that our clinic escorts wear to easily identify them, because as we know, those who oppose abortion wouldn't wear a rainbow for what it symbolizes. But I'm going to stop now, but our escorts, they rock.
Thank you so much, Tammy. Carol, did you want to add something on the volunteers who help support?
Well, it was a transformative experience for me to visit Tammy's clinic, and I mean, Fargo is by and large, North Dakota is a conservative state. Fargo is bluish in some respects, but the true blues found themselves and created this extraordinary community, around the clinic. And it was really, this was some years ago, and I just still remembered the warmth, and the comradeship, and it was really a beautiful thing to see.
Francine?
Yeah, what's coming out here is the importance of community. Honestly, it's the courageous folks are the people in the local communities, and they're Plancy just finished a full what they call. I'm no longer part of Plancy. I'm retired, but I'm so proud of what they're doing. They just went on a road trip into every state. And the way they did it was by partnering with local groups and giving them funding to be able to be the ones to put up art, to put up murals, to do radio shows, to do all sorts of very creative ways of getting the word out about the fact that people have options in these very, very, very difficult states. And how creative they were, and how willing they were, and how courageous they were to talk about this in these very difficult states, it's just really inspiring.
Thank you all for sharing that. I think we can get to one more question. David, this one was for you, asking if you could say more about why we think the Trump administration has not moved more aggressively to enact the anti-abortion wish list.
Yeah, so I want to be clear, they have done a bunch of things, right? Like they have, just like every Republican president coming into office, reinstated the Mexico City policy, which limits or restricts American funds being used abroad with respect to any organization that helps with reproductive health. They have pardoned the FACE Act people in jail who have terrorized people in clinics, and then said we are not enforcing the FACE Act except if there's extreme circumstances, or as we saw last week with what happened in Minneapolis, the FACE Act, which prohibits blockading and violence around abortion clinics or reproductive health clinics, also has a separate provision that protects churches and religious entities. That was put in for political compromise in 1994. And we saw last week the Trump administration trying to enforce that part of the FACE Act without extreme circumstances, right? There was no violence or death involved there. And they're going after people in Minneapolis using the FACE Act. So, and then, they've done other tweaks around Medicaid and around Department of Health and Human Services. So there have been anti-abortion policies from the Trump administration. But I do think that the two biggest asks from the anti-abortion movement that I mentioned before, the Comstock Act and the FDA, they have not done. And so why? There are various theories out there, right? Certainly the Trump administration is not shying away from doing things that are considered outrageous, that are considered unlawful, that are considered unconstitutional. So they're not shy about doing things that are consistent with what he believes. So there is some sense that, he just doesn't care about abortion one way or the other, or maybe even he's pro-choice. He used to be pro-choice. We all know that. But that he just used abortion to get elected and to rile up his base now that he doesn't need to be elected again. That he's not doing what the anti-abortion group really want. So that's one possible explanation. Another possible explanation, which is related, is that he has his eyes on the midterms and the 2026 midterms, and knowing that the party that has the presidency usually loses by a lot in the midterms. That's the general trend in American politics. He doesn't want to make it even worse for the Republican Party, knowing that the country is very pro-choice. And so if he did one of these two things or both of these things, it would inflame the public and hurt his party even more at the ballot box in November. So if you buy that explanation, then there is some concern maybe after the midterms he might go for one of these things or both of these things. And as I always say when I talk about this, I have no crystal ball. No one has a crystal ball that knows what's going to happen in the future. All I know is that we are now a year and 15 or 16 days into this second Trump presidency, and he has not done these things. And I think every day he doesn't do things, it's more likely he's not going to do them in the coming days, that it's just not his priority. These other things are his priority: attacking trans people, attacking immigrants, acquiring Venezuela, Greenland, and Canada. I don't know what those things are his priorities, and abortion just isn't. But I don't know if there are other ideas that people have that I haven't. Please feel free, because this is obviously a huge what's going on? I don't know.
Yeah, it's another surprise, right? It's another surprise in addition to the numbers. And, as Francine has talked about, and all of you have talked about, like access to the pills has been a key source of continuing access to abortion care.
And just to be clear, it's not for lacking of the anti-abortion movement trying to get him to do these things. They have written every week. There's another letter that senators, that anti-abortion leaders, that churches have been writing him, pleading with him to do these things. And every week goes by and he doesn't do anything.
Yeah. Well, I think our time is almost up. I want to thank you all so much for this just so helpful and such an important discussion on what is actually happening on the ground and, giving us some hope, but also recognizing there's a lot of work to still be done. I hope that everyone will read David and Carol's wonderful book. And thank you very much for joining us. I'll turn it over to you, Asha.
Wonderful. Maya, thank you for your leadership in putting together this important conversation. David, Francine, Carol, Tammy, I know we learned a lot, and I know that it's been so important for us to learn about the work you're doing and the impact that you're having. So thank you. I also want to call out a couple other folks who help put together events like this. As you can imagine, we rely heavily on our AV team, so we want to thank them and our special events team. We also had a wonderful captioner who was helping us provide the live captioning. Thank you. We also want to thank our marketing team led by Keith Pierce, because, of course, being able to promote these events and making sure we reach the wonderful audience that we've had today is so important. Please keep in mind, we at the AUWCL Health Law and Policy Program have a wonderful spring semester ahead with a couple of more events that I think you're going to find interesting. I'm going to post a couple of things into the chat right here as well. We're also going to be emailing everyone who registered with the recording for today's event, but also information about these upcoming events. One of them is going to be a wonderful book talk, and this is going to be with Grace Howard. Having a chance to learn insights from her about her book entitled The Pregnancy Police: Conceiving Crime and Arresting Personhood. This is going to be on March 2nd in person at our campus in Washington, D.C. Another wonderful event that we're partnering with our students on is the Revolutionizing Drug Development program we're doing, the impact of AI in pharmaceutical development. This program is going to be both virtual and in person, so I hope you'll join us for that. And that's going to be coming up in March as well, on March 4th. And so I've included some of the registration information in the chat. So with that, I just want to again thank everybody. And again, don't hesitate to reach out to us at any time. Look out for the email from us. You can also just reach us at health@wcl.american.edu. So that's pretty easy to remember. And so with that, I wish everyone a great day and thank you again for joining us. Take care.